So the talk that I'm going to give is about treatment intensification in locoregionally advanced disease. I will show you my disclosures. Let me see. I don't think that has any interference with what I am going to tell you. Let me start by saying that concurrent platinum-based chemoradiotherapy is at this moment the preferred non-surgical treatment for locally advanced squamous cell carcinoma of the head and neck. And until recently, the high-dose regimen, the 100 milligram per meter squared 3 times during radiation, was based on 4 large phase 3 trials, which I will show you in a minute. And I think the superiority over radiotherapy alone was again confirmed in the 2 recent de-escalation trials that compared the high-dose cisplatin with radiation versus cetuximab with radiation. This was done in the patients with HPV-associated oropharyngeal carcinoma, as you know. A last point with respect to the importance of the dose is the cumulative dose. And there are at least 2 reference papers, one by Strojan and the other by Sprefico, that suggested that at least a cumulative dose of 200 milligram per meter squared is recommended. Now, the 4 large randomized trials you see here on this slide, Edelstein and co-workers did the study in patients with unresectable disease. Forestier did it for organ preservation, as you know, in larynx cancer. And then there are 2 studies where the patients received concurrent chemoradiotherapy versus radiotherapy after surgery. The one by Bernier in Europe and Cooper in the United States. And all these studies clearly showed that there was benefit in terms of local control or disease-specific survival or overall survival. But in all of them, there was clearly much more acute toxicity with the concurrent chemoradiotherapy. The 2 other studies that you see at the bottom were performed in France, and they made not use of the high-dose cisplatin, but they used the combination of carboplatin infusional 5-FU during the radiation. And these were also 2 reference papers that we make use of when we talk about evidence-based medicine. Now, the problem of high-dose cisplatin during radiation is, apart from the acute toxicity, mainly the late toxicity. And what you see here, this is a paper by Martaille that was published already in 2008, showing that about 40% of the patients that are being treated with concurrent chemoradiotherapy suffer from severe late toxicity. And as an example, I think that the 13% of feeding tube dependency at 2 years after treatment is really very alarming. The majority of patients have problems with swallowing, and this may lead later on and after years to pneumonia and even death due to this complication. And in this analysis, there were even 10% of patients that have unexplained death. So this is a serious problem. So for that reason, we have looked for ways to diminish these toxicities by having improvement in radiation. And you have heard already a beautiful report on the role of proton therapy this morning or this evening. But there are several other improvements like swallowing sparing, IMRT, stereotactic radiotherapy. And apart from the improvements in radiation, there have been alternatives for the high-dose 3-weekly cisplatin. And one of the points that I would like to make clear to you is that if you know a little bit about the pharmacology of cisplatin, then you will understand that fractionating or fractionation of the dose or lowering the peak levels will have major impact on the toxicity. And so I show you here some important studies that have been done in order to look whether other treatment schedules of cisplatin could be used. There was a retrospective analysis, a meta-analysis, that showed here that if you compare the high dose with the low dose in conventional fractionated radiotherapy, that we could not find a difference really. But of course, these retrospective analyses have biases in itself, and therefore the prospective trials are very important. I think one of the trials that was performed in your country and published by Dr. Noronha in the Journal of Clinical Oncology was an important one because it's one of the first that really looked at it prospectively. They compared at the Tata Memorial Hospital the 100 milligram per meter squared every 3 weeks with the weekly very low dose of 30 milligram per meter squared per week. And the outcome of the trial was that there was a difference in local regional control in favor of the high dose regimen. You see also that because of this difference in dosing, that the cumulative dose also differed. And I think that that's one of the reasons that they found this difference. And therefore, the Japanese study that was published this year, again in the Journal of Clinical Oncology, was very important for the decision-making whether the weekly regimen could replace the high-dose 3-weekly regimen. So this was a study that, just as was done by Dr. Noronha in about 90% of her patients, it was done in the postoperative setting. And they used not the 30 milligram per meter squared, but the 40 milligram per meter squared. And therefore, the cumulative dose in both arms of the study was comparable. Now, this study showed non-inferiority of the weekly regimen in comparison to the high-dose 3-weekly regimen. In fact, if you look at the survival curves in the paper, then the weekly regimen is on top of the 3-weekly regimen. So I think this is a very strong argument to say that in the post-operative setting, most likely the weekly regimen is equal, at least equal to the high-dose 3-weekly regimen. Another trial of interest is the GORTEC trial, where they split up the dose of 100 milligram per meter squared to 4 days of 25 milligram per meter squared per day. And the outcome of this trial was, because of the lowering of the peak dose, the toxicity was clearly significantly less, with grade 3-4 toxicity 35% versus 65% in favor of the fractionated dose, while the efficacy endpoints were exactly the same. So improvements are possible. And if we look now at the 3 de-escalation trials, the 2 with the high-dose regimen, and the one that was recently published from Australia with the weekly dose with conventional fractionation again, the dose was 40 milligram per meter squared per week. Then I'd like to your attention to the fact that you see that the compliance of the regimen in all circumstances was quite okay. But if you look at grade 3-4 late toxicity, then it's clear that the weekly regimen is, in that sense, less toxic. And if we look at, for instance, the feeding tube dependency at 2 years, that was clearly lower with the weekly regimen in comparison to the 3-weekly high-dose regimen. So this is an indirect comparison, of course. And so I think that this is still not the final answer for the definitive chemoradiotherapy setting. And we have to wait here for the US trial that is ongoing. That is an NRG trial, head and neck 009. And that is comparing the high dose 3 weekly versus the weekly low dose, both in HPV positive and in HPV negative tumors. So that will finally give an answer for the definitive setting. So without surprise then to you, if I show you here the NCCN guidelines, the last version, then you see that in the definitive setting, there are two regimens that are being advised. That's the high dose cisplatin, and it is the carboplatin infusional 5-FU, the French regimen. If we look now at the postoperative setting, then you see that the advice is simply cisplatin. That means they accepted that both the high dose 3 weekly and the weekly low dose are being advised. And this is advised for the patients that are considered high risk and have no oropharyngeal cancers. And with high risk, as you know, we talk about patients with positive margins or extracapsular spread. So this is what is now standard. So the point is, are there patients that need even stronger therapy than concurrent chemoradiotherapy? And is it possible to do that? And I think that I summarize here for you what are the categories of patients where you could consider a more intensive treatment. First of all, these are the fit patients with locoregionally advanced squamous cell carcinoma of the head and neck. And that if you look at the scoring according to the UNC criteria, then we have to say that there is immediate risk HPV positive patients and the high risk HPV positive of HPV negative patients, but all oropharynx cancers are considered categories of patients where you would like to see a better survival. That's of course not the case for the so-called low-risk patients. There the de-escalation trials are being performed, but in the other groups, oropharynx cancers, improvement is something that you would like to see. And the same is true for all non-oropharyngeal cancer patients. Another group where you would like to see a better outcome are the fit patients with locoregionally advanced head and neck cancer that are candidates for concurrent chemoradiotherapy in the post-operative setting. I just showed you that. And then there is a group of patients with oligometastatic disease where also additional treatment of the distant metastasis may play a role. So also there, an intensification of the treatment is something that we would like to see. Now, what options do we have for intensification? We can consider adding more cytotoxic chemotherapy. We can think about adding targeted therapy. We can think about adding approaches that increase the radiosensitivity of hypoxic cells. And we can think also about adding immunotherapy. And what I will do is I will show you some examples where I think that the direction might go, where some things may be very promising, others are less promising. I think it's interesting to have a sort of overview of that. Let me start by saying that the randomized trials where we use induction chemotherapy followed by concurrent chemoradiotherapy versus concurrent chemoradiotherapy alone, all the trials so far have shown that they are all more toxic when you add more chemotherapy. And none of these trials that I show here, the 4 trials here, did not show a survival benefit. There is an Italian trial that was published by Dr. Guy, but that trial has a lot of complications in its in the way it was performed, because halfway the trial a different control arm was introduced. So that is a very difficult to evaluate trial, but the majority of the trials are absolutely negative in survival benefit, and they all show more toxicity. And this is more or less confirmed by a meta-analysis that was published already some time ago by Zhang and co-workers, showing that there is no difference in outcome whether you add induction chemotherapy or not. What it did show, however, was that it had an effect on distant metastasis. So in those patients that are candidates for developing distant metastasis, and I'm thinking now about patients with massive multiple lymph nodes, especially when they are located in the neck, or when you have METIT metastasis. These are patients most likely that are prone to develop distant metastasis, and therefore trials that make use of a better selection of the high-risk patients in that respect is something that I still look forward to see them coming up. Adjuvant chemotherapy after concurrent chemoradiotherapy. Well, you know, just as I do, that giving chemotherapy after concurrent chemoradiotherapy is very difficult for the patients to tolerate. More than 50% of the patients stop this type of treatment early. And therefore, if we take into account that also the Pignon meta-analysis never showed that there was an established role for adjuvant chemotherapy after concurrent chemoradiotherapy, I think that this is not an approach that is getting a lot of enthusiasm. However, there are some data, especially in nasopharyngeal carcinoma lately, that suggest that a simple adjuvant therapy that is not too toxic could have a beneficial effect. There are two trials at least that were recently reported, one from Maio and one from Chen, where patients were randomized to receive concurrent chemoradiotherapy followed by adjuvant chemotherapy versus concurrent chemoradiotherapy alone. In the first study, it was making use of capecitabine given 2 times per day for 14 days every 3 weeks and for 8 times. And in the other trial, they used a very low dose, more or less metronomic type of treatment, again with capecitabine. And it showed, especially in the last one, that grade 3-4 toxicity occurred only in 17% of the patients, while the failure-free survival was significantly different in favor of the capecitabine arm. Now that is interesting, and there are some retrospective studies, especially in how shall I say that, in locally advanced squamous cell carcinoma of the head and neck, other sites than nasopharyngeal carcinoma, making use, for instance, of UFT or S1 that are showing a similar sort of outcome. But of course, these are retrospective analysis and need to be further assessed in prospective manners. So I think that that's something that needs to be looked at. Now, what about targeted therapy? As you know, EGFR targeting agents have been used a lot in head and neck cancer, and especially cetuximab, which is the only monoclonal antibody that is available in US and in Europe, has been used for that. It has shown that it has beneficial effect when added to radiation, but also it is increasing the response and survival in the recurrent metastatic disease setting when it's combined with platinum-based chemotherapy. And in your country, I think that also nimetuzumab is available, which has shown some promising data lately also. We, apart from the monoclonal antibodies, we have the small molecules, and especially some of them, lapatinib and afatinib, have been tested in the adjuvant setting, and also in addition to concurrent chemoradiotherapy. There are two studies that I like to mention to you with respect to the addition of anti-EGFR monoclonal antibodies to the concurrent chemoradiotherapy. One is the RTOG protocol 5022 and the trial from Tata Memorial Hospital. The first one is making use of the addition of cetuximab, and the second one is making use of nimetuzumab. The first trial was negative in outcome, so it seemed to be that the addition of cetuximab had no impact on outcome. It was inducing 10% more mucositis. And so the general conclusion of the trial was that it was a negative trial. However, some subset analysis suggested that younger patients might show some benefit of adding cetuximab, and also HPV negative patients might show that. This is something that came forward stronger in the Tata Memorial Hospital protocol, where there was a significant difference found here, as you see here, in the progression-free survival data. Again, also at the cost of 10% more mucositis, so it's not without negative aspects, but I think this was an interesting observation. And they looked a little bit further at that, which patients did benefit most. And again, when they looked in the group of HPV negative oropharyngeal cancers, they found a difference, as you see here, which suggests that there was a benefit of the addition of nimetuzumab. Now, the point is that in the American trial, they used high-dose cisplatin during radiation, and in the Tata Memorial protocol, they used the 30 milligram per meter squared. And I think that that may play a role in whether or not the nimetuzumab had a positive effect or not. So it's not sure that the nimetuzumab would do the same benefit when you combine it with the high dose. So the suggestion here was that the outcome of this regimen is a good alternative if 3-weekly high-dose cisplatin is not feasible. I agree with that, and I think that further studies with nimetuzumab is certainly worthwhile. I can be short about adjuvant targeted therapies with small molecules. There are 2 large trials, one with lapatinib and one with afatinib, that are absolutely negative. So I think there's no role for adjuvant use of the small molecules. Now, I think this is extremely interesting. Talking here about IAPs, those inhibitors of apoptosis proteins, they are frequently overexpressed. You see them here. They're overexpressed in various tumor types, and they have a critical role in primary and secondary resistance. And I think that xavinapant is the first drug that's becoming available. The radiosensitizing effect of this drug is mediated through activation of caspases, and also has an effect here on modulation of immunotherapy and inflammatory reactions. So they have influence on these pathways. So that's quite interesting. So the expectation was that if you block the IAPs, that it would lead to an enhancement of the effect of radiation and an enhancement of an effect of cisplatin. So therefore, this was tested in the clinic, first with a phase 1 trial looking for the dose, and they came to a recommendation of 200 milligram per day. It's a drug that's being given orally. And then they tested this drug in a randomized phase 2 study, where they give it together with concurrent chemoradiotherapy, 14 days every 3 weeks. They started during the radiation, and they gave also 3 cycles after the radiation. And the control arm was concurrent chemoradiotherapy, again with a high dose cisplatin plus placebo. Now, the primary endpoint was a difference in local regional control rate at 18 months. And when that would not have succeeded, the trial would have stopped. But fortunately, as you see here, there was a difference, as you see here. This is the experimental arm, and this is the control arm. And there was a difference that was indicated. Here was beyond the level of what was planned to be seen. You see here that the local control with the combined arm is clearly better. Now, later follow-up at 3 years showed that there was a major difference in progression-free survival. You see here a hazard ratio of 0.34, p-value of 0.0023. And what's even more striking, after 3 years, there is a difference in overall survival with a hazard ratio of 0.49. Again, significantly different. And I must say, this is unprecedented. I've never seen in this poor group of patients benefits with a new treatment like this. So this is extremely promising, and a phase 3 trial at this moment is ongoing. Now, one of the major hurdles that we have in radiation oncology is a radio resistance due to the heterogeneous hypoxic areas in most solid tumors. Now, to overcome this, you have several approaches. You can think about increasing oxygen delivery. You can think about radiosensitizing hypoxic cells. You can think about preferentially killing hypoxic cells. You can think about vascular targeting therapies and radiation-based approaches. What I'd like your attention for is that there are some drugs that may be familiar for you, of course, and that is Nemorazole, which is a drug that's being used in Denmark at this moment routinely in the treatment of locally advanced disease. Tirapazamine, which has been studied in the past, but is not being used routinely now. And what is also very interesting is that you see that hyperthermia is playing a role in different approaches. So it's playing a role here in increasing oxygen delivery. It's playing a role in radiosensitizing hypoxic cells. It's playing a role in preferentially killing hypoxic cells. It's playing a role in angiogenesis effect, so the vascular targeting therapy. So this is playing a role here also. So that means that in fact hyperthermia is one of the best modifiers of hypoxia. And it's interesting to realize that this has not been studied extensively lately, and you just wonder why that is. I think that if we look at modification of hypoxia, then the meta-analysis that was published by Jens Overgaard already in 2011 is quite interesting. You see that local, regional control and disease-specific survival and overall survival are all improved by modification of hypoxia. It has hardly any effect, of course, on distant metastasis. And what's very important, it doesn't seem to enhance the late toxicity. So I think that this is one of the reasons also that in Denmark, where Jens Overgaard is working, this is now based also on one of the Dahanka trials, the Dahanka 5 trial, where they compared the addition of Nemorazole to radiation versus radiation alone. That is now their standard treatment. Now, they are at the moment further studying this in combination with concurrent chemoradiotherapy, and in their hands, it's still a very promising result. And we have tried in Europe to confirm this by a trial in collaboration with the Danish group, where they, the patients that were candidates, they were looked for whether they had a hypoxic gene signature, and then they were randomized to receive concurrent chemoradiotherapy with nimorozole or concurrent chemoradiotherapy plus placebo. Again, here the patients were allowed to be treated with high-dose cisplatin 3 weekly or the low dose weekly. Now this trial was interrupted because of major toxicity that was observed in the high dose cisplatin arm, so that was skipped. But then later the trial was stopped because there was no difference found in interim analysis between the two arms of the study. So unfortunately, we have not been able to confirm the data on the role of nimorozole as an addition to concurrent chemoradiotherapy. And finally, hyperthermia. I mentioned this is in principle very promising, but there was a meta-analysis published here in 2016 that clearly suggested that there was a benefit. You see the complete response rate by using hyperthermia in addition to radiation is clearly better with the combination. And the toxicities, as you see here, were more or less similar. Nevertheless, despite this data, there are not many studies performed prospectively. And I think one of the reasons was that the apparatus that they had to use to give adequate heating in the head and neck area did not exist. Now, they have now new models developed as in Rotterdam. It's a sort of collar that they can bring around the neck of the patients. And that is, I think, much more promising. And I expect that we will see the coming years trials where hyperthermia is being used. And I think comparing what we have seen, for instance, in women with cancer of the uterine cervix, there we have found significant benefit of adding hyperthermia. Survival benefit is as good as with concurrent chemoradiotherapy. So we have examples that there is a potential beneficial effect of adding hyperthermia to chemotherapy and radiation. You may have a lot of expectations on immunotherapy, but I show you one slide on this. There are at least 4 trials where the addition of checkpoint inhibitors, whether it is pembrolizumab or it is avelumab or nivolumab. Well, nivolumab I have to wait here, but at least here with pembro and avelumab, we have negative trials by the addition of the checkpoint inhibitors at the time of radiation or chemoradiotherapy. Unfortunately, that is not so promising. You can discuss what could be the cause of that. What seems to be more promising, though, is the use of induction with checkpoint inhibitors. And this is one of the examples that I show you as an illustration, where here the patients are first being looked for what the CD8 cell density is at the first biopsy, and then the patients are being treated with a combination of cisplatin and docetaxel plus durvalumab and tremelimumab, which is a CTLA-4 blocker. They gave 1 cycle, and then they repeat the biopsy. And what they found at interim analysis, that by just giving 1 cycle of chemoimmunotherapy, there was a pathologic complete response rate of 47%, and an additional 25 patients out of the 57 that they were tested at this interim analysis had an increase in intraluminal CD8 cells. What they did was, when such patients were available, then they gave the immunotherapy, they continued that during the radiation. If the patients did not show a pathologic complete response or an increase in CD8 cells, then they received the standard chemoradiotherapy. Now, this is something that looks, again, quite promising, and that is something that is further tested now in prospective trials. So my conclusion, Mr. Chairman, is that what can we say about intensification now in locally advanced head and neck cancer? I think cisplatin-based concurrent chemoradiotherapy is standard of care in non-surgical approach in fit patients with dose-limiting toxicity. Toxicity of high-dose cisplatin might be reduced by dividing the dose over several days, facilitating adding new modalities. Promising data with targeting agents like nimetuzumab and xevinapant and hypoxic modification in HPV or P16 negative patients seems quite interesting. The role of checkpoint inhibitors during concurrent chemoradiotherapy is disappointing at this moment. However, the role before or after local therapy is at this moment unclear and maybe much more promising. And I think that hyperthermia is, I can only conclude on saying that it seems to be a forgotten area and it needs to be tested in the coming years more strongly. Thank you very much for your attention.